Hi, everyone. Welcome back to another episode of Beyond the Script. Today, we have Dr. Subodh Verma. He is a cardiac surgeon scientist and professor at the University of Toronto. He holds a Tier 1 Canada Research Chair in Cardiovascular Surgery and a past recipient of the Howard Morgan Award for Distinguished Achievements in Cardiovascular Research and the Royal College of Physicians and Surgeons of Canada Gold Medal in Surgery. He is here with us today. Thank you so much for being here.
It's my pleasure, Ivy. Thank you.
Can you first just tell me, what does a cardiac surgeon do and how is it different from a cardiologist?
Well, thank you. So I'm a heart surgeon at St. Michael's Hospital at the University of Toronto. And, heart surgeons and cardiologists often confused, right? By the public often think that cardiologists and heart surgeons do the same thing. And, we work very collaboratively together, but we have slightly different skill sets. So cardiologists really are involved in sort of the day-to-day diagnosis of heart disease, all of the medical aspects of heart disease. If a patient has chest pain or shortness of breath or palpitations, they usually will be seen by a cardiologist, and they'll sort of work up the patient with respect to what are the problems. If someone has chest pain or shortness of breath, they'll look for, whether there's underlying blockages in the heart or heart failure signs, etc. But if something needs to be fixed, surgically, that's when heart surgeons are involved. So that's what I do. We do sort of the actual surgical work. So that involves, at least in my case, opening up the chest, opening up the breastbone, and actually directly repairing the heart, whether it is bypass surgery, i.e., fixing the plumbing of the heart, or whether it's actually fixing the valves in the heart, or, in some cases, heart failure surgery, heart transplants. The surgical aspect is sort of complementary to what the cardiologists do, but quite unique in terms of our training.
So do you make diagnoses as well?
Yeah, we do. Of course, we make diagnoses as well. We treat patients, but we really are working sort of in a fashion that is complementary with cardiologists. So most of our referrals, for example, come from cardiologists who've diagnosed the problem and then have asked the cardiac surgeons to sort of fix that problem. And then in some cases, the care is shared after surgery with a cardiologist and a cardiac surgeon. And in many cases, we actually will hand the patient back to the cardiologist to sort of manage their post-operative course.
Wow. I didn't know that distinction was there.
So we have patients come to us all the time, sort of, asking that question.
I bet,
what is the difference? But
yeah, there you go. So, so what goes through your mind when you're about to literally cut someone open and operate on their heart?
Yeah, so it's a question we've been asked I've been asked many times, and as you can imagine, we take the work exceedingly seriously, right? So although we've trained, and in my case, I've been doing this for over 2 decades at St. Michael's Hospital. We've operated on thousands and thousands of hearts. It might be the 5,000th surgery for us, but it's the first one for a patient. So I think always recognizing the gravitas of the moment for people is really important. And I think that's what at least I do and most of my colleagues do as well. So it's a serious business. The room for error is very small. Every sort of millimeter makes a difference. Every decision can lead you down either a good or a bad path. So, most things are, we manage sort of in an algorithmic fashion. So we have a systematic way of assessing patients, a systematic way of getting ready for surgery, not just in terms of preparing the case and working within the team in the operating room, but also mentally, you have to sort of get into the right framework, the night before surgery, the morning of surgery, and really trying to ensure that you clear your mind of anything else that's going on so that all you're thinking about is the person in front of you, the heart in front of you, and the seriousness of what that means to that person. Because, at the end of the day, that person has a wife and has a husband and has a child and has a brother and has a friend who's actually waiting for them.
Yes.
And those are the people that we feel highly accountable to, not only to the patient, but to, everybody else that's around them.
How much training does it take to get to the point where you know exactly what millimeter of a cut you need to make to get there, to do it confidently?
So most individuals who go into heart surgery have to do, medical school.
Mm-hmm.
Medical school requires first an undergrad degree in most cases, and then 4 years of medical school, about 6 or 7 years of cardiac surgery training, plus 4 or 5 years of a graduate degree, because most people actually do not only cardiac surgery, but also, as is my case, we also do a lot of research and work as a professor at the university. So, all in all, it's about 20 years after you 20 years of university, if I may, to get to this point. And I think that's how it should be, right? Because the stakes are high, and you want to make sure that the people who are operating on you are people who are well trained and are able to do this complex work carefully.
Absolutely. And with 20 years of training, would you go back and do it all again?
Oh, I would do it again for sure.
Yeah.
The heart is just one of the most wonderful organs in the body, and you have to be in love with the work that you do, right? And I still, as I tell my trainees, when we open the chest and we open the pericardium and we see this sort of really wonderful organ beating, it's really the centerpiece of life, right? It's it has so many meanings for so many people. For some people it's a pump, for others it's a sign of love, for others it's a sign of affection. But at the end of the day, this is one of the most miraculous organs in the body. You can just see the strength and the power. When you think of it, this organ beats 100,000 times a day. It beats 3 billion times in your lifetime. And it does that through, every moment, when you sleep, when you're awake, when you're exercising, through the good times and the bad times.
Yes.
It's always there. It's there in the most selfless fashion. It asks for absolutely no recognition. And it's doing this, in such a unbelievably coordinated fashion. You can't believe, billions of cells coming together, speaking to each other, spontaneously working in a sort of collaborative fashion. It's just one of the absolute miracles of nature. So every time I see a human heart, I still am in complete awe of how this absolutely phenomenal machinery comes together, beat to beat, to support every single cell in the body.
Yeah.
It's amazing. It's just truly amazing.
Yeah, and that's amazing what you said. It's always there. It's selfless. And, of course, you would have a perspective that so few other people would have, because most people are generally, if they're walking around and doing their normal day, they're not thinking about their heart that's working for them in order to do that. But you see hearts all the time, and you see ones that don't work as well. And so know how much it means to have one that really does work.
But I'll tell you one thing, Ivy, and that is that the heart always wants to beat. And we see that. It's got such a spirit to it. It always wants to beat. And although we see hearts sometimes that are not doing that well, the intrinsic drive is always there. It always wants to beat. Now, as heart surgeons, we often have to stop the heart. In most cases, we have to stop the heart to be able to operate on the human heart. So the actual heart is stopped. And that's why the heart-lung machine actually takes over for that time of the operation. Now, people ask this all the time, do you stop the heart? And the answer is yes, 9 times out of 10, we have to stop the heart for the duration of the operation.
I had no idea.
Exactly.
Wow.
So that, too, is it's a really important, message for people that when we do stop the heart, you're supported with a heart-lung machine. But the heart wants to come back. It wants to start beating again. And it's just incredible to see how nature has instilled in it this sort of independent, spontaneous, unrelenting sort of capacity to just keep on beating. It's just one of the most, it's a miracle.
It's incredible to hear you talk about that.
Yeah.
Thank you for sharing that in perspective. I imagine there are moments, of course, during surgery where things go wrong, and things go wrong in a potentially fatal way. How do you stay calm in those moments, and how do you navigate what to do in those moments?
Right, so 2 important questions. One is, how do we manage those intraoperative and difficult decisions? And I think first we're trained to recognize those. And as they say, an ounce of prevention is worth a pound of cure, and that is that we try to stay away from areas and things that can actually, take us down the wrong path. And I think that's why the training is so long.
Yeah.
And the more you do it, the more you recognize where you could get into trouble and how to stay out of trouble. So half of the battle, if not more, is to just stay away from danger.
Okay.
And to be able to anticipate and predict where problems may arise. Maybe it's the wrong patient you're taking to the operating room. Maybe the patient is too high risk. So sort of making sure you've looked at everything preoperatively. And, as they say, the best preparation for a good operation is good preoperative preparation and good sort of, a good idea as to what you're going to do. Because you shouldn't have to really be thinking too much on your feet about, new concepts and new ideas when you're in the act of executing a plan. So in most cases, when you end up in the operating room, you have a very clear path and a very clear sort of plan that you would like to execute. Now, sometimes the train can get, derailed. And in those cases, we have to be able to quickly adapt. We have to stay calm. We have to make sure that we can call for other help. And sometimes other surgeons will join us. And sometimes we just need to take a step back and take a time out to sort of really think about what are the right steps to move forward. And that doesn't happen very often.
Yeah.
But when it does, staying calm under pressure, recognizing sort of the seriousness of the situation, and making sure that you, again, you're practicing with the most important principles as a doctor and as a surgeon, and that is do no harm, right? As doctors, that's the first sort of principle that we practice, and that is, before we want to do something good, we have to make sure that as surgeons and as doctors, we don't do anything that can harm a patient. And as they say, that's the first principle. And I always find myself sort of going back to that. I'm risk averse, and I always sort of take a step back and say, I want to make sure that whatever decisions we're making right now are safe. Whatever decisions we make right now are in the best interest of the patient. And I think I would say that most of my colleagues practice in the same kind of vein.
Can you explain to me a time where things didn't go as planned?
Oh, there's so many examples, right? And most of the time, they have ended up with, good solutions, right?
Okay.
So sometimes things don't go the way you anticipate.
Yeah.
And cardiac surgery is not a sport for people who can't readily think on their feet and can't readily problem solve and find alternative solutions. So, there are many such examples where you are surprised by things that you haven't seen before, and you need to adapt. It doesn't happen often. The more you've done this, the more you've sort of seen all of the permutations and combinations.
Yeah.
But it requires the ability to be flexible, adapt, and seek, assistance if required.
Yeah. How do you decide if you should operate or shouldn't operate?
Right. So, that's an important question for people as well. So we get just for example, people are referred to us who need bypass surgery. Bypass surgery is one of the most common operations done for heart surgery.
Oh, okay.
This is when people, have their chest open. We take some vein from the leg, we take arteries from the chest, and we really recreate and reconstruct the plumbing, if I may. And there's blockages because of risk factors. People are getting, chest pain, shortness of breath, or have had a heart attack, and we have to really, create alternative routes for blood supply, and that's what a bypass operation is. And, there are guidelines, first and foremost. So the good thing is that most things that we do are backed by Canadian or American or European clinical practice guidelines. Now, not everything has a guideline, and guidelines are not commandments, but guidelines are a way for physicians throughout the world to think through a problem set and say, for a person presenting with these problems and these types of sort of conditions, they should get this type of an intervention. So what that does is that if you, for example, were a patient who went to Calgary and you saw a heart surgeon in Calgary, they would also be practicing sort of within those clinical practice guidelines to say people who have, let's say, 3 blockages in the heart and have type 2 diabetes, they're better served with open heart surgery than having a stent. And if that is a guideline recommendation, then most people will try to, as I say, sort of color within the lines,
Right.
will practice within that scope of practice. And that's how decisions are made for the very most part in heart surgery.
Okay. And if you're explaining something like this to a patient, how do you explain to them to the best of your ability in a way that they can understand the risks of something? And how do you go about reassuring a patient that maybe this is a scary operation, but is probably the best option for you?
Right. So this is something we deal with every day.
Yeah.
And, truth-telling is very important, but you have to do it skillfully, and you have to do it without withholding anything in terms of the risks and benefits, but also, reassuring people that this is the right sort of trajectory or path for them. So I think we have to use simple language, language that is factual, but not too many adjectives. It can't be things that scare people, but it has to actually also convey the fact that this is a serious operation. And I think all of us get pretty tactful to make sure that we can communicate that. But for your viewers, I think it's important to know that, heart surgery today can be done with very low rates of morbidity and mortality, that most centers in Canada and throughout the world, have published kind of statistics around their outcomes, and that the decision to have heart surgery is often made after multiple physicians have looked at your file, right? Not just your family doctor, but oftentimes the emergency room physician, the cardiologist, the interventional cardiologist. In many cases are brought in front of what we call a heart team, where a team of experts sit together and say, this is the right way of approaching them. And therefore a lot of thought goes into ensuring that patients, when sent to us for heart surgery, which clearly is the most invasive option, have carefully gone through the process of sort of vetting other scenarios and other sort of less invasive options.
That's very interesting to hear, because I wouldn't know. I've never had heart surgery before. I wouldn't know that it's maybe a group of people deciding that this is your best option. It's not just one person saying this is a good idea. And even if it was, I would trust you as the one person being a heart surgeon. But it's really comforting to know that a lot of people are saying this is the best option.
Right. So I think people should recognize that over the last sort of decade or so, there is a very strong evolution of what we call the heart team.
Okay.
And the heart team is a team of cardiologists, anesthesiologists, cardiac surgeons, and others who come together where cases are presented so that they can be carefully evaluated. Is surgery the right option? Is a stent the right option? Should they have their valve repaired or replaced with an open incision or with a clip? And we're so fortunate, at least in Canada, to have wonderful collaborations across the heart team that allow for thoughtful, careful decisions to be made. And I want people listening to know that this is serious business for us, and we know that their lives are important. We know that decisions we make are important, and we think about that all the time.
Yeah. And do you think about it in a way that keeps the magnitude of what you're doing at the forefront, but not so much that it scares you while you're operating?
Great question. Yeah. So we understand the gravitas and the magnitude and the seriousness, but we have the confidence to be able to execute that, and I think that's really important.
Yeah.
Yeah.
Is there? This might sound silly, but is there such thing as a minor heart surgery or procedure, or are they all pretty intense if you're operating
they're
on
all
the
pretty
heart?
intense. At least for the types of cases that we do as open heart surgery, of course, there's different types of, but every open heart operation that requires a patient to go on a heart-lung machine is a major operation. Yeah.
What's the general demographic of the people you're operating on?
Great question as well. So many things to say here. First and foremost, the people that I operate at St. Michael's Hospital, they come from a diverse ethnic background. We tend to see more South Asian patients, and there's a reason for that, and that is that South Asians are at higher risk of cardiovascular disease
Really?
compared to, let's say, other ethnic groups. We see both people who are in their sort of younger as well as older individuals. And there's a common misconception that heart disease only affects older individuals, and I can tell you that's not true at all. Right? So we see younger and younger individuals with heart disease.
Wow.
We see males and females. Often people think that heart disease is a male-dominated disease. That's not true as well. So really, the demographic is, I would say, on average, my list will have in a week, a few people who are in their 70s, a few that are in their 50s, and sometimes people who are in their 40s as well. So it's the entire spectrum of individuals. We tend to see people with multiple risk factors.
Okay.
Now, there are risk factors for heart disease. So people who have had a heart attack or someone who's had angina or blockages, they usually have risk factors such as diabetes or smoking history or overweight or obesity, physical inactivity. And in some cases, there are no risk factors. There's sort of genetic risk factors. Mom had a heart attack or dad had a heart attack at a young age. So, we see the entire spectrum of individuals in our operating room.
Yeah, that's so interesting that you debunked a few myths there, that it's not just one group of people, it's not just one gender, it's not just one age group, and people can have heart issues, unfortunately, at pretty young ages, and it doesn't excuse you. You're not immune to it, I guess.
Well, the biggest myth, Ivy, is that we hear that, I exercise a lot and I'm not living with overweight or obesity, so I'm going to be fine. And I can tell you that's not the case.
No.
Because you can't have 3 donuts a day and try to exercise that off.
Right.
That doesn't work.
Yeah.
Okay? And or I only smoke 2 cigarettes a week, and that's going to be okay.
Yeah.
Or I'm young and I'm not going to be. I won't get a heart attack. So the reality is that heart disease remains the #1 killer.
Wow.
And most of heart disease is preventable.
Really?
That's true. Yeah. So
Wow.
that data is coming out, repeatedly. That 80% of heart attacks can be prevented by intensive lifestyle modifications.
Yeah.
Knowing your numbers, as I say, know your blood pressure, know your cholesterol. Eat well, exercise, manage your stress. Those are all things that, if done consistently over a long term, can go a long way in preventing heart disease. Sometimes
I hear about stories where people have issues who I would look at and think, wow, that person does everything right, and this has still happened to them. Do you see that in your practice?
We see that, and we are less surprised by it because we see it quite frequently. But it's a big shock to people, right?
Yeah.
You can imagine someone who is, 35 or 40 years of age, who may be running marathons, and this has happened to me, and now suddenly is faced with needing open heart surgery, right?
Wow.
And they say, I eat well, I'm in good shape, I run a marathon, and I've got young kids at home. How did this and where did this come from? And the reality is that we have some insights about how heart disease develops in terms of risk factors. We know that, smoking is not good for the heart, and high sugar and diabetes is not good, and high cholesterol is not good, and high blood pressure is not good. But all of those risk factors don't always explain why some people develop heart disease. And many times there's sort of unmeasured risk factors, and one of them is called lipoprotein A, or LPA. Recently in Canada, we've asked that every Canadian have their LPA measured. Now, this is not a routine blood test. It's not something that we usually measure. It's not part of a cholesterol profile. So you have to ask your doctor to, order an LPA.
Okay.
Now, LPA is a genetic marker of risk. You were born with a certain amount of LPA, so was I. Now, I could run a marathon, it wouldn't change my LPA. I could gain weight or lose weight, start smoking or quit smoking. It's not going to change the LPA because it's what you get from your parents or grandparents. Now, it turns out that LPA is about 10 times as atherogenic as LDL cholesterol. So, people talk about cholesterol all the time. But imagine, mole for mole, LPA is 10 times more likely to cause heart disease than high cholesterol.
Wow.
And most people don't know that.
No.
So, measuring your LPA would be important. And we've seen many cases now where there are people who are looking at us saying, "What?
Yeah.
Me?" Or you're looking at somebody saying, "How's that possible?"
Yeah.
She's 40 years old. She's in good shape. She eats well. I've had people say, I went out, my wife said, I went out with my girlfriends, and nobody eats as well as she does.
Yeah.
Nobody exercises as much as she does.
Yeah.
Look at how good of a shape she's in. How did she need heart surgery? And then, surprise, the LPA was elevated. So,
wow.
Measuring your LPA is quite important in terms of knowing your risk. And if you have a family history of heart disease, sort of recognizing that is also equally important.
Yeah. Thank you so much for sharing that. I had absolutely no idea, and I'm sure probably a lot of people just learned something
It's
from
just
that.
evolving. The science of LPA is evolving, but I think the viewers watching, they should know that LPA, at least if you're in Canada, is covered by your sort of insurance and by your public health, and you should get your LPA measured.
What's maybe a big mistake people make when it comes to their heart health?
Is thinking that they're not going to be the one.
Yeah, that's scary and probably very realistic.
It is.
Yeah.
It's not going to be me, it's somebody else. Or, maybe I don't need to worry about it now.
Right.
Remember, heart disease, taking care of your pump is your responsibility. And, we can't control what we bring to the table in terms of genetics.
Right.
But we definitely can control things that are in our hands. So, if you smoke, you should quit. If you are physically inactive, then you should try to incorporate physical activity. Sleep is emerging as, the other fourth sign. We talk about, the 4 S's, salt and sugar and stress and sleep.
Yeah.
Know your 4 S's outside of your other risk factors.
Yeah.
So stress and anxiety are now really emerging as being bona fide important risk factors for heart disease. So just being, although the organ, as I said, beats spontaneously, does not require any input from you in terms of what it does day in and day out. But taking care of it is in your hands, and I think that people need to really invest in that.
Yeah, and no one can do it for you. You have to do it yourself.
That's right.
Yeah.
That is exactly correct. Science is getting better, but, we are also competing with an unbelievably unhealthy environment, in many ways.
Yeah.
Right? So, food choices, unprocessed foods, high sugar content in foods, high salt content, high stress, poor sleep patterns, sedentary lifestyles. It's becoming harder and harder to keep the heart healthy because, we're balancing all of those other things that are really taking away from heart health.
Yeah.
So as I tell the students and residents and patients and others, you're in charge, right?
Yep.
You have to be accountable for your own pump.
Yes.
And do what's in your hand. And if you do the right things, long term, they do pay dividends.
Yeah. Wow. Are there any symptoms that are relatively common symptoms that people ignore, but actually might be a sign of?
Good question. I'll answer it 2 ways. One is general symptoms that most people think about.
Okay.
And then symptoms that women should not, overlook because, that's an area of great interest to mine and something that I'd like to chat about.
Yes.
So the first thing is, the usual symptoms are, if you get short of breath, going up a flight of stairs, if you're getting short of breath and you were fine, let's say a week ago or 2 weeks ago, and you progressively feel like you're getting short of breath. The other one is chest pain, and chest pain is often, you go to your doctor, they say, any chest pain? Now, chest pain is usually a feeling of chest discomfort. You're going up a flight of stairs, or as I'm chatting with you, or you get stressed out, it's not really sort of pain per se. It's a sense of chest heaviness or discomfort.
Okay.
Sometimes you feel that after a meal, or you feel it sort of generalized around your chest, or often it could go into your jaw, or go into your back, or into your arms. Those are often signs of that worry doctors that there could be a problem with the heart. And unlike what people think is that chest pain must be sort of one specific spot, that's not the case. Palpitations, where you feel like the heart is skipping a beat, or oftentimes now people have Apple Watches or other types of electronic devices which will often say, you've got an arrhythmia or an abnormal heart rhythm. That can also be a sign that you should, check in with your doctor. Other signs are, leg swelling. Leg swelling can be a sign of heart failure in patients. If you notice that your ankles are swelling up, you should check with your doctor for sure about that. Now, the reality is that many of these so-called symptoms don't occur in everyone. Right?
Okay.
And people can present with no symptoms, with just the first symptom being he was fine, and at night he had the first symptom, which was chest pain, and he had a heart attack. So oftentimes the first sign and symptom of heart disease can be that first heart attack, and or unfortunately in some people death, right? So unless you've sort of really understood your risk factors leading up to that, you can get into trouble. So the fact that you've never had any symptoms doesn't mean that the first symptom will not be a heart attack. Now, I want to just mention to you that women do have, can have a different sort of symptom presentation. And it's very important for your listeners to know that you can't say that men's symptoms are typical and women's symptoms are atypical when, why are men's symptoms not atypical and women's symptoms typical? So this whole thing that they say, women's symptoms are atypical, I think what people are trying to say is that they can have different presentations as opposed to what has been classically taught through the lens of looking at men with heart disease, right? And I think this is really important because the rates of heart disease in women are high, they're growing, and they're often not recognized. And it really annoys me quite frankly,
of course.
because women often are, their symptoms are ignored, or they get sort of subpar care, or they get fewer diagnostics, or they're often brushed away. No, this is not a problem.
Right.
And I think we've got to stop doing that. We've got to recognize that this is a problem. It affects men and women, and women's symptoms may be different than the so-called classic symptoms that I've just presented to you. So always being vigilant, and if something has changed, bring that to the attention of your doctor and say, I'd like to make sure that my heart is okay. And that's been a great mission of many of us to sort of really move the field in that direction.
Yeah. Thank you so much for speaking on that. That's such a huge topic of, like you said, women versus men. And I like what you said about why are women's symptoms the atypical? They're just different.
They're just different symptoms.
That's all it is. Yeah.
So, I often see people say, well, symptoms of women are atypical. And, that's a medical term, but what does that mean? Like,
Right. It's
a different way of the symptoms present differently in different sexes. And I think that needs to be appreciated. And, we have to, women's hearts matter, and they matter just as much as everyone else's. And often we have to close that gap. The gap has to close in terms of better ways of recognizing, treating, and ensuring that the outcomes are similar. I was struck just a few days ago. The American Heart Association published stats on forecasting the outcomes of heart disease in women by 2050. And it's scary, right? It's really scary. It's just published. 2050 is just 25 years away or 24 years away. And the numbers are alarming. That the rates of heart disease will be skyrocketing in women not cancer, not Alzheimer's disease, but 1 in 2 women will be living with a chronic heart condition. And I think that's serious.
1 in 2 women.
That's right.
Wow.
And there's disparities, right?
Yeah.
Black women, Hispanic women, minority groups have a disproportionate burden of these disparities. And I think that, it just, I think in 2026, it's unacceptable.
No.
Yeah.
You said the rates are skyrocketing, unfortunately. Why do you think they will be so high by 2050?
A good question. I think demographic aging, people getting older, and risk factor burden, overweight, obesity, diabetes are really major contributors to cardiovascular disease. And we have to recognize that, more sedentary lifestyle.
Right, yeah.
And more access to processed foods, excess body weight.
That makes sense, unfortunately. But I have a last couple of questions before we wrap up. I would love to know, what's a patient story that you'll never forget that really stuck with you?
One in particular that comes to mind is, I was on call, and this was a gentleman that had actually, I think, was up north, canoeing, I think, and fell into the water. And he actually drowned. And he was, I think someone from a distant area saw him and sort of, got him out of the water. And, I think he had no pulse, but he was cold, ice cold. And he was taken to the closest hospital where he was rewarmed and resuscitated. And by all accounts, he was dead, but I think being in the water in the cold, kept the heart safe, and kept the brain safe, and he was rewarmed, and he came back to life, and he was found to have a very significant problem in the heart that caused the heart attack at that point in time that caused him to flip over into the water. So we got him at the hospital, and I did his operation. And I was really glad to see that he did well. So there are many such sort of stories of the miracles, right? That really stay in your mind. Yeah. They're the good stories. And they're the ones that keep you up. Yeah. Because at the end of the day, we're heart surgeons. We deal with these, life and death situations every day. But we are humans too. Yes. Right? Yeah. And, when we lose a patient, we take that on our shoulders too. I bet. So, that's just life. That's a good one, though, that you can remember positively. For sure. There's so many good, positive stories. Yeah. And it is such a privilege to be able to take care of people in the most vulnerable times of their life. Yeah, and absolutely. To give them and their family a chance. And, in my office, I have a picture of my family. Yeah. And I look at that all the time. I've got lots of pictures of my family, not because I forget them, because I'm at home all the time, if I'm not working and I see them all the time, because taking care of your heart and taking care of someone else's heart is not just for them, right? Right. It's for those pictures. It's for those people. Yep. And because somebody's waiting for you. Yes. Yeah. And that matters. And, if your wife was having open heart surgery, you would want the surgeon to think, this is someone's someone's wife, someone's mother, someone's sister. Absolutely right. Yeah. Someone's waiting for you. Yeah, and, absolutely. We are here to hopefully help. Yeah. Thank you so much for sharing. I have one last question. It's kind of a playful one, but is there, when you're in the operating room, are you chatting? Are you listening to music? Are there certain songs that you like to have on when you're operating? Yeah, I think every surgeon is different. Many of my colleagues, they play music. Many of them like it quiet. Yeah. I think there are points where there's conversation going on, and then there's points where we like absolute pin drop silence. Okay. And, I'll just tell you, my routine, and that is usually, when we stop the heart, I usually will say silence in the room. And I everybody knows that about me. Right. Silence in the room is not about no chit-chat. It's about the whole team recognizing that this is now the time for focus.
Yes. I think that will make a lot of people comfortable to hear that, since it's good, you're operating on a heart and you want to be completely focused on what you're doing. The person's, like you said, it's the most vulnerable they can be. Their chest is open and exposed, and that's something no one else sees. So
that's right, and I'll say that there's not a lot of, sure there are light moments, but I would say for the most part, the patient in front of us entrusts us with so much, right?
Yeah.
And I want them to know that we respect that.
Yes.
In every sense of the word.
Yes, absolutely. Thank you so much for sharing all of this.
Pleasure.
So interesting. So
Thanks,
nice to
Ivy.
meet
Same
you.
here. All the best.
This is Dr. Subodh Verma. You can find him on Instagram. He's an amazing cardiac surgeon. Thank you so much.
It's my pleasure.
Bye.